Dear colleagues and friends, ladies and gentlemen, good evening and welcome to this virtual meeting that's held as a cooperation between the Egyptian Association for Endocrinology, Diabetes and Atherosclerosis, the IADA, and the Italian Diabetes Campus. This event will be in two waves, this wave today and tomorrow. And the program is sponsored by AstraZeneca. Actually, I have the pleasure to co-chair this event with my dear friend and colleague, Professor Paolo Pozzilli. And now, may I ask Professor Pozzilli to give his introductory speech. Professor Pozzilli, please.
Hello and good morning. Or good afternoon. It's a great pleasure to be here with my Egyptian friends to share this very interesting session at the Congress of the Egyptian Association of Endocrinology, Diabetes and Atherosclerosis Congress. We have a very interesting session today with topics that are covering the most attractive new development in the field of diabetes and its complications. First of all, we have my talk about the role of diabetes and the bone, something that has not been discussed very often, but you will see that this is an area of great interest and new development. There will be lectures followed by topics that are well known and relevant for diabetic patients, including the diabetic cardiomyopathy, and then the issue related to how to manage patients with type 2 diabetes that can be treated either with insulin or the GLP-1 receptor agonist. We will follow talking about the relevance of new strategies for prevention of type 2 diabetes and how that has to be implemented in the present context. For type 1 diabetes, I will discuss with you the new technology and how the new technology is changing the way how we treat patients with type 1 diabetes. Then there will be an interesting presentation regarding LADA and the new strategies to treat LADA after the paper we have published in Diabetes with other international colleagues on a consensus for treating LADA according to the C-peptide residual beta cell function. And finally, we will have a presentation about SGLT2 and how SGLT2 are now having a strong impact in type 2 diabetes, in particular for prevention of cardiovascular disease now, and the new guidelines revisited for treatment of type 2 diabetes. I'm sure that that will be a great section, and I look forward to this presentation and the discussion that may emerge. Thank you.
Professor Yahya Ghanem will moderate the first session today. As we know, Professor Ghanem is emeritus professor at the Faculty of Medicine, Alexandria University, and he is the ex-chairman of the Internal Medicine Department. Ustaz Yahya, please.
Bismillah ar-Rahman ar-Rahim. Professor Amara, thank you very much. You are my tutor and my boss. It's always a great pleasure to work with you. Now let's go to work. The first presentation is going to be by Professor Paolo Pozzilli. Professor Pozzilli is going to talk about recent advances in bone and diabetes. This is a very important topic which has been emerged later on. Professor Pozzilli, thank you very much. Let's go to work. Thank you, Professor.
Good evening, ladies and gentlemen, dear colleagues. It is my great pleasure to give you this presentation on the recent advances in bone and diabetes. This is my disclosure. Well, in this presentation, I'm going to present 4 different topics: the mechanism that link diabetes with bone disease, the bone disease in type 1 diabetes, the bone disease in latent autoimmune diabetes in adults, a form of autoimmune diabetes that has an onset in adult age, and in type 2 diabetes, and drugs that are used for treatment of hyperglycemia and their effect on bone disease. So what can we say about a link of bone disease and diabetes? First of all, there is no question that the fragility fractures are increased in both patients with type 1 and those with type 2 diabetes. And this is associated with an increased morbidity, mortality, and healthcare costs. The risk of fracture is increased at all ages, both in males and females, and increases further above that of the general population with aging. There is a close correlation between glucose levels and bone metabolism, and this is relevant also in terms of preventive strategies of fractures in patients with diabetes. In this cartoon, the cellular and molecular mechanism of bone diseases in diabetes are represented. From one side, both the bone demineralization and also the decreased bone turnover may be taken into account, and classical mechanisms that can lead to bone disease. But the pathogenic factors that are more relevant include the adipose tissue, an increase of adipose tissue that's typical in patients with type 2 diabetes in particular, that can have an effect of the osteoblast activity and osteoblastogenesis, and also the effect of other factors like insulin deficiency and IGF-1, insulin deficiency typical of type 1 diabetes, and the IGF-1 that may have an effect on the reduction of osteoblastogenesis. On the other side, what about the osteocytes and the osteoclast activity? Here, we know that in type 2 diabetes in particular, there is a loss of incretin effect, and this loss of incretin effects with reduction in GLP-1 and GLP levels can actually have an effect on osteoclastogenesis. And on the other side, we have the cytokine storm associated with activated T cells that have an effect on the activation of osteoclastogenesis. And on the other side, we have hyperglycemia associated classically with diabetes, both type 1 and type 2, an increase of non-enzymatic glycosylation of collagen, a factor associated with an increased risk for bone disease. So if we look at bone disease and type 1 diabetes, and the prevalence of skeletal health in patients with type 1 diabetes is here represented. This is a large study in 31,000 patients with type 1 diabetes compared to 300,000 patients as control. And as you can see that there is an increase related to age, but even young patients have an increased hazard ratio of developing fracture in patients with diabetes, but that is increases with age and reaching highest ages around the age of 60, 69, and of course associated with other factor linked with an increased age. So the interesting aspect is that in type 1 diabetes, the increased risk of fracture is already apparent early in the disease process. So suggesting that indeed the lack of insulin in early age, in particular in children diagnosed with type 1 diabetes, may have a detrimental effect. Regarding the site of fracture in patients with type 1 diabetes, the risk of hip fracture has a very high relative risk compared to other fracture, the vertebral fracture, and you can see that there is a relative risk of 2, and the estimated fracture risk considering the BMD, the body mass density, is also increased, and also when you estimate fracture by FRAX, suggests that patients with type 1 diabetes have a serious problem with their bone. And of course, because these are younger patient, and fracture associated with this patient can increase tremendously the risk for fracture, and of course the increased mortality associated with cardiovascular disease later on in life. If we look in this review of the association of type 1 diabetes and fracture risk, these are different studies where always you see that the relative risk and the hazard ratio is increased in all different studies. And in particular, you can see that the hip fracture, as I mentioned before, is the type of fracture that is most associated with patients with type 1 diabetes. And you can see in this study is a prospective observational study. The risk is relative risk is 7. And also in this other study that is meta-analysis observational studies by Vestergaard, the relative risk is 6.9. One of the potential mechanisms associated with bone disease in type 1 diabetes is the cortical bone size deficit that has been observed in adult patients with type 1 diabetes. The differences in bone geometry associated with that can be explained by differences in body composition of bone turnover associated with hyperglycemia, and in particular may be associated with glycemic variability. That is one of the most serious problems associated with patients with type 1 diabetes, with period of hyperglycemia as well hypoglycemia, and as well as a higher bone marrow fat content that has been shown in patients with type 1 diabetes. So given the importance of bone geometry to the overall fracture risk, we may say that the cortical bone size deficit may contribute to the increased fracture risk that has been shown to be associated with type 1 diabetes. Type 1 diabetes and the skeletal integrity and strength in adolescents assessed by high-resolution peripheral computed tomography for clinical imaging of bone architecture. This is a very interesting paper recently published by Devaraya, where you can see that the microarchitecture of the bone, and this is the tibia in patients with diabetes, is altered compared to the microarchitecture of patients with of control patients. And you can see here also the radius. This is the radius slice, and this is the radius in 3 dimensions. You can see that the microarchitecture is highly affected in patients with type 1 diabetes. And then in particular, the fact that in earlier life and diabetes type 1 with insurgence in earlier life, bone architecture, microarchitecture, and strength rather than bone density could explain the increased risk of fracture that are then observed, the increased risk observed in adult patients with type 1 diabetes. Here in this slide, we look at the risk factor for fragility fracture in patients with type 1 diabetes. Now, here we have the increased risk of 1 fracture, and here the same factors associated with increased risk of 2 or more fracture. As you can see, parameters taken into consideration include the HbA1c, the disease duration, the family history, the eGFR, and the presence of neuropathy. And as you can see, there is a tendency clear for an increased fracture in patients with type 1 diabetes, in particular associated with family history for fracture, and also for the presence of neuropathy. It is another increased factor. But then if you look at increased risk of more than 2 fractures, other parameters are becoming significant. In particular, you can see the HbA1c greater than 0.79, and then the family history is still present, and we have neuropathy, and that is a limit of significance that could be associated with increased risk. And also poor metabolic control, also glycated hemoglobin between 7.2 and 7.9 is very close to significance. And therefore that underline again the importance of the glycemic variability to explain the increased risk for fracture in patients with type 1. Another aspect that I briefly mentioned before is the increased bone marrow adiposity and skeletal fragility. Now, hyperglycemia increases the expression of PPR gamma genes, which stimulate differentiation of mesenchymal stem cells into bone marrow adipocytes. And if we think for a moment that the TZDs, the thyroideones, are used for patients with type 2 diabetes, even though more recently less than before, that are thought to increase the risk fracture through promotion of marrow adipogenesis at the expense of osteogenesis. And in animal models of type 1 diabetes, hyperglycemia has been shown to be associated with an increased marrow adiposity and bone loss. But data in humans are not so consistent. But there was one study that recently showed a lack of association between the MAT and type 1 diabetes in young women compared to healthy control. Regarding measures to detect the increased fracture risk and how to intervene to prevent fracture in patients with type 1 diabetes, these are the guidelines issued by the International Osteoporosis Foundation, that a T-score less than or equal to 2 for patients with diabetes age 50 or with risk factor for fracture should be taken into account as a threshold for osteoporosis in patients with type 1 diabetes. Also, the vitamin D supplementation may be beneficial in type 1 diabetes due to low levels of vitamin D in these patients. This has been demonstrated also at disease diagnosis, and patients with long-standing type 1 diabetes very often are associated with low vitamin D level. So I recommend that vitamin D should be often measured in patients with type 1 diabetes to be sure that these patients do not suffer from deficit of vitamin D. And also the hypoglycemic events may be reduced now with the technology associated with the management of diabetes. I think hypoglycemia and the counter response with hyperglycemia should be really tackled if we would like to reduce the risk of fracture in patients with type 1 diabetes. And as you can see here, the anti-osteoporotic treatment with the T-score at this, as I said, equal or less than 2, alendronate is the first line choice. And then reduce faults of hypoglycemic events, and that is what I mentioned before. And this is again where we should pay much attention, in particular in the elderly patients, when we should try to use more and more the continuous glucose monitoring. So in summary, the skeleton is adversely affected in type 1 diabetes. Patients of both sexes have an increased risk of fracture that starts early in childhood. And type 1 diabetes is characterized by a mild to modest deficit in bone density, structure, and especially microarchitecture. And the observed bone deficit in type 1 diabetes results from an impaired bone formation rather than an increased bone resorptions. And the more recent data indicate that bone quality is impaired in type 1 diabetes, and then could explain the finding of risk fracture that is elevated out of proportional to the degree of bone mineral deficit. Now going to discuss the bone disease in latent autoimmune diabetes in adults, LADA, a form of autoimmune diabetes with an insurgence in adult life, characterized by development of beta cell failure and requirement of insulin after 3 to 5 years or even longer, diabetes is diagnosed. And then in type 2 diabetes. Now, if we compare type 1 diabetes, LADA, and type 2 diabetes in terms of normal BMD, osteopenia, and osteoporosis, in this paper recently published in Diabetes Metabolic Research Review, and this is the first paper comparing these particular aspects in patients with LADA and other type of diabetes, you can see that the osteoporosis percentage is still very high in type 1, and in type 2 is definitely less, but LADA with 45% positivity is the in-between type 1 and type 2. So indeed, LADA very often is called as a form of diabetes in between type 1 and type 2 diabetes. And also in relation to osteoporosis, we may say that LADA is in between. These data suggest that screening for osteoporosis and prevention of osteoporosis among patients with LADA should be taken into account. This is particularly true because these patients may have a very low beta cell function. And when they start insulin therapy, indeed their beta cell function is deficient. And this could be a reason why they develop osteoporosis similarly to patients with type 1 diabetes. Regarding the bone disease and LADA, we have to pay attention to sclerostin because sclerostin is an antagonist of bone formation that is increased in patients with type 2 diabetes only. This is a paper we published recently in JCM, and no data are available on LADA that, as I said, clinically can resemble type 2 diabetes at onset because there are patients insulin independent. But at the same time, these patients have an increased prevalence of the metabolic syndrome. So they are phenotypically more similar to patients with type 2 diabetes rather than type 1. But with time, they tend to be more similar to type 1 rather than type 2. And also remember that several immune and genetic factors in LADA similar to type 1. And so some investigators define this form of diabetes as a subtype of type 1 diabetes. And I suggest you look at the review article, the consensus paper we published in Diabetes recently, where we define the management of LADA. Also, the evidence that the Wnt is differently regulated in type 1 compared to type 2 LADA, and type 2, and of course, LADA may have a compromised skeletal phenotype in between type 1 and type 2 diabetes. If we look at the sclerostin level I mentioned before and bone turnover, and you can see what's happening in type 2 diabetes in LADA and non-diabetic control, you can see that bone resorption is reduced in both LADA and type 2 diabetes compared to non-diabetic subjects, whereas circulating sclerostin is increased in type 2 diabetes only, likely due to the association between sclerostin level and metabolic syndrome that, as I mentioned, is more prevalent in type 2 diabetes than in LADA. Here we have again the sclerostin level in patients with type 2 diabetes with or without metabolic syndrome. And as you can see, there is a difference. Patients without metabolic syndrome tend to have a lower sclerostin level. And this is in patients with LADA, and those with metabolic syndrome versus those without metabolic syndrome differ in slightly in terms of their sclerostin level. This is a later paper published by our group in JBMR, where we look at the sclerostin bone gene expression in type 2 patients. These are female patients, and as you can see, this is the higher expression of sclerostin bone gene patients with type 2 diabetes compared to control. So this is a consistent now evidence that sclerostin level in patients with type 2 diabetes are increased compared to control. Bone disease and medication for diabetes therapy. This is the last part of my presentation. And of course, in patients with type 2 diabetes, we have a number of drugs that are used, which can indeed affect either bone formation or bone resorption. And this is true for in vitro studies, in vivo animal studies, and human in vitro. And as you can see here, these are the results regarding sulfonylureas with plasma of minor effect of the different drug on the bone resorption. And so you can see that this is interesting data in vitro, we have not consistent data in trials looking at this particular effect, also because some of these trials are low in terms of follow-up. But anyway, we have to keep in mind that some of these drugs may have an effect on bone metabolism, and of course need to be considered when the patients are diagnosed with osteoporosis or at the risk of fracture. Some drugs, and I focus in particular to TZDs, where we know that the bone formation clearly is reduced. Now, so in conclusion, ladies and gentlemen, type 1 diabetes is associated with insulin deficiency and impaired bone homeostasis. And this is a fact that need to consider bone disease as another complication associated with type 1 diabetes, in addition to the classical complication as retinopathy, neuropathy, and nephropathy. Poor glycemic control, higher insulin dosage, older age, longer duration of diabetes, and age less than 20 years at diagnosis, family history of osteoporosis or osteopenia are then definitely associated with the increased factor, with increased risk of fracture in this patient and worsening of BMD reduction. In patients with type 1 diabetes that have microvascular complication, lower BMD, this is another potential factor associated with risk of fracture linked to bone vascularization as one of the potential mechanisms associated in the pathogenesis of bone disease. What about children and adolescents? They have a smaller cross-sectional areas and weaker bone, despite an increase in bone formation markers, suggesting that there is indeed an impaired osteoblast activity during growth. The early recognition of abnormalities in skeletal status and body composition is important in young adulthood when peak bone mass is achieved. For treatment, of course, the vitamin D should be monitored, and it may help in order to reduce progression towards bone disease. Insulin and IGF deficiency are a major pathogenic mechanism involved with glucose toxicity, bone marrow adiposity, inflammation, adipokine, and other metabolic alteration that all may play a role in altering bone turnover. What to do to prevent and have a potential beneficial approach for treatment? Lifestyle modification is clearly, in particular, physical activity should be taken into account seriously for these patients, in addition to the fact that they are diabetic, but in particular for prevention of osteoporosis. Hypoglycemic agents may have also an impact on risk of fracture. So the presence of family history for osteoporosis and fracture should be taken into account when we look at the hypoglycemic agents that should be given to this patient. TZDs may accelerate bone loss and increase risk of fracture, particularly in older women. Metformin and sulfonylureas do not appear to have a negative effect on bone health. Animal models indicate a potential role for incretin hormones in bone metabolism, but these are data limited to DPP-4 inhibitor and GLP-1 agonist. The effect of insulin on fracture are controversial. Some studies show an increased risk and others showing no effect. And the SGLT2 inhibitors do not appear to increase fracture risk. But in general, patients with type 1 diabetes should be always considered as patients at risk for osteoporosis, as we have seen, and so the selection of drug to be given needs to be carefully evaluated. In conclusion, bone disease in diabetes is a serious complication of these conditions. There are a number of key factors listed in this slide that we need to take into consideration for prevention of bone disease in diabetes, including the family history for osteoporosis, the importance of physical exercise to prevent obesity, insulin and IGF-1, presence of vascular complication, the duration of diabetes, the presence of hyperglycemia, and drugs that need to be considered for treating hyperglycemia. By keeping in mind all these factors, we can try all our effort to prevent the insurgence of this complication in patients with diabetes. Thank you very much.
Professor Buzili, thank you very much for your comprehensive talk about bone disease and diabetes. You talked about type 1 diabetes, DALADA, and type 2. Thank you for these informations. Thank you again. Rahman Rahim. Again and again, I have to thank Professor Amara for allowing me to share with you this topic. Definitely, the topic of diabetic cardiomyopathy, is it a reality or just a fancy name? I have an agenda which we are going to spend 20 minutes over there. What is diabetic cardiomyopathy? Is diabetic cardiomyopathy common? What is the mechanism behind diabetic cardiomyopathy? How to diagnose diabetic cardiomyopathy? Can we treat diabetic cardiomyopathy? The notion about diabetes and heart started after the year 2007, after the big scandal which has been published by Nathan about the TZDs and the heart. That draws the attention of many diabetologists about what about the heart and diabetes. That's why Professor Amara asked me today to talk a little bit about diabetic cardiomyopathy. The phrase diabetic, or the sentence diabetic cardiomyopathy, entered literature the year 1972. There was a debate about the existence of distinct diabetic cardiomyopathy. There was a series of professors. Leo reported a condition where there is a ventricular dysfunction in absence of coronary artery disease. After a few years, Budini stated with the European Society of Cardiology that there is an affection of the ventricle in absence of both of coronary artery disease and hypertension. Later on, Angie suggested that not only should be both coronary artery disease, hypertension should be absent, but other cardiovascular conditions such as valvular heart disease. So it sounds to be that diabetic cardiomyopathy is non-coronary, non-hypertensive, non-valvular affection of the myocardium in diabetic patients. A more recent proposed definition of diabetic cardiomyopathy was definitely that there is a cardiac abnormality wholly explained either with not explained either by cardiovascular or non-cardiovascular causes, likely due to diabetes. This is a very important slide. Please concentrate a little bit with me there, because this is the classification of diabetic cardiomyopathy, which has been published 2 years ago in the Advances of Endocrine Metabolism 2019. We have 3 classifications according to cardiomyopathy, according to New York Heart criteria, or the American College of Cardiology or the American Heart Association. And we will see they are all sharing some characteristics. Concerning cardiomyopathy staging, stage 1, there is a diastolic heart failure with normal ejection fraction. Stage 2, there is a symptomatic heart failure combined with systolic and diastolic dysfunction. Stage 3, symptomatic heart failure, but there is hypertension, microvascular disease, but no coronary artery disease. Stage 4, there is a symptomatic heart failure, but there is a coronary artery disease. New York Heart Association stated that class 1, also asymptomatic, no limitation of physical activity. Stage 2, slight limitation during ordinary physical activity with fatigue and palpitation. Class 3, marked limitation with symptoms occurring during minimal physical activity. Stage 4, New York criteria, symptoms are present at rest, unable to carry the normal physical activity. Lastly, but not the last, the American College of Cardiology and the American Heart Association stated that stage A, at a risk of heart failure, but no structural heart disease. Stage B, asymptomatic structural heart disease. Stage C, there is symptoms of heart failure with no structural changes. And lastly, stage D, refractory heart failure and dyspnea at rest. What about the incidence? The incidence of diabetes in patients with heart failure in the Haram trial was around 7.8 over 2.8 years. Over 3 years, there has been around 8% of the patients with diabetes in heart failure Haram study. But the prevalence actually was around 25 to 40%. Yes, we are facing a problem. But please look at this last sentence. Unrecognized diabetes or pre-diabetes are also common in patients with heart failure. In the paradigm heart failure, in unrecognized diabetes, there was around 13%. In pre-diabetes, it was 25%. That's to say that pre-diabetes is a very important stage, that 25% of these people are having heart problem. Please look at this schema. I tried to simplify it very much because Professor Amara always says, when you make a cartoon, make it simplified. Symptomatic changes in diabetes lead to increased angiotensin II, the hazardous, advanced glycation endoproducts, hyperglycemia, hyperlipidemia, insulin resistance, lipotoxicity. They all lead to changes in cellular metabolism, mitochondrial dysfunction, oxidative stress, will lead to changes in the endoplasmic reticulum and leads to changes in inflammatory markers. They will lead to endothelial damage and last in myocardial ischemia. Also, they play an important role in the profibrotic response leading to cardiac fibrosis. The oxidative stress will increase cardiomyocyte death, cardiomyocyte hypertrophy, and cardiac hypertrophy. Lastly, these mitochondrial changes, please look at the word mitochondrial, because futurely we are going to use this word. It will lead to cardiomyocyte calcium dyshomeostasis, and all these four mechanisms will lead to, unfortunately, cardiac dysfunction, diastolic and systolic dysfunction. There are investigations to be done. Diabetic cardiomyopathy is a condition which is not currently diagnosed clinically. The European Society of Cardiology heart failure guidelines stated that there is gaps in evidence. Typical symptoms combined with elevated beta type of natriuretic peptide can indicate the presence of heart failure, but they are not specific for diabetic cardiomyopathy. B-type natriuretic peptide. Similarly, an abnormal echocardiogram or cardiac MRI can indefinitely structural abnormalities, but not that these are due to diabetes. Endomyocardial fibrosis, this is an invasive procedure. If it is done, there is increasing collagen and fat deposition in left ventricle and transmural biopsies. The other invasive story is the cardiac catheterization to exclude a coronary artery disease. But the most important sentence or phrase in this cartoon is that an end diastolic pressure more than 16 millimeter mercury in the left ventricle may confirm diastolic dysfunction. This is very important. Increase in end diastolic pressure more than 16. But unfortunately, the biopsy and cardiac catheterization are invasive procedures. Let's go to imaging. What about imaging? We have different modalities. First of all, an echocardiography, either the conventional one or tissue Doppler or the speckle tracking echocardiography. They are good, but the conventional has a problem in intra-observer variability. There is an angle dependence and noise interference. For tissue Doppler imaging, this is non-discrimination between passive and active motion. Lastly, speckle tracking echocardiography, irregular ventricular remodeling, and wall thinning. This is the echocardiography. What about the MRI, which is a very important modality, but unfortunately, it has an important drawbacks such as claustrophobia. We need sometimes a pacemaker and underestimation of diastolic dysfunction. Lastly, but not the last, concerning imaging. What about the multiple slice CT? This is a computer processed combination with X-ray imaging, but unfortunately, the patient will be faced with radiation and contrast media. What about nuclear imaging? We have the G-SPECT and the PET. Unfortunately, high complexity, there is radiation and impairment in tracer uptake. This is a very important slide. Other than the clinical picture and other than the radiology, what about the biomarker, especially when you said that the beta natriuretic factors are not specific? Cardiac autocrine and paracrine or excreted molecules could be released from diabetic heart in response to damage following maladaptive mechanism associated with structural and functional alteration. Chronic, late, irreversible events such as inflammation and apoptosis detected by markers such as CRP or CKMP may not provide a valuable information. However, detection of early reversible responses such as hypertrophy, contractibility, steatosis, or even fibrosis by related factors might be optimal for diabetic cardiomyopathy. This is a very important. The last slide. I think this is a very important slide. This cartoon presents, these are the biomarkers for diabetic cardiomyopathy, either in humans and animals. I will stress a little bit about in humans that cardiotropin, increased transforming growth factor beta, procollagen type 1, insulin-like growth factor binding protein, and activin play a role in diminishing contractility, increasing fibrosis, and increasing cardiac hypertrophy. These are the biomarkers which has been published later on in Diabetic Cardiomyopathy Heart Journal. What about the pharmacological intervention? This is my last section, but I think we are going to hear a little bit some question about this story. What about the pharmacological intervention to reverse cardiovascular dysfunction in type 2 diabetes? This is a very big issue. How to reverse cardiovascular dysfunction in type 2 diabetes. ACE inhibitors are recommended within the European Society of Cardiology and the European Association of Study of Diabetes for diabetes and impaired glucose tolerance. Again, for diabetes and pre-diabetes in the CHARM, ATLAS, and HELA trials. They all have shown the beneficial effect of the use of ACE inhibitors in heart failure in terms of morbidity and mortality. However, in subgroup analysis, there was no difference in improvement between diabetics and non-diabetics. The second class or the second classes after ACE inhibitors, there is a similarity for improvement with mineralocorticoid antagonist, nitrates, hydralazine, ivradapine, which is the procorolan, and recently the sacubitril valsartan, which is called ARNI. This is the whole medications which are used. The ACE, mineralocorticoid antagonist, ivradapine, and sacubitril valsartan. Still, glycemic control, despite the mega studies, but glycemic controls are very important. The impact of better glycemic control on left ventricular systolic and diastolic dysfunction remain debatable due to the varying evidence from the UKPDS Advanced Accord Vedant. Unfortunately, they didn't show any improvement in cardiovascular outcome in good glycemic control, except in the legacy effects of the UKPDS or advance on. Let's go to work. Now we are going to the recent years. We hear a lot and the changes in guidelines. What about the new medications which are used in atherosclerotic coronary artery disease? Number one, the GLP-1 receptor agonist, the glucagon-like peptide receptor agonist. They have a cardiovascular benefit, but they are multifaceted. They lower the blood glucose, they lower the blood pressure, especially with exenatide and liraglutide. They have a protective effect against the endothelial dysfunction. This is a very important story because the lining endothelium of the vessels is the endothelium. Liraglutide can improve nitric oxide synthase, which improves nitric oxide, diminish plasminogen activator inhibitor, diminish vascular adhesion molecules. Lastly, this glucagon-like peptide receptor agonist decrease atherosclerotic progression, myocardial ischemia, such as exenatide and adjacent therapy in STEMI and thrombolysis. These figures represents different GLP-1 receptor agonists. In the leader study, the liraglutide, they improve heart failure hospitalization and 3-point MACE. When they used in the Harmony, the albiglutide, they improve heart failure hospitalization and the 3-point MACE. Also in the Excel study. And we see also in the Pioneer study, there has been improvement in hospitalization of heart failure and 3-point MACE. Yes, when we talk about GLP-1 receptor agonist in treatment or prevention or reversible or heart diseases, we should talk about the newcomer in the paradigm for treatment of type 2 diabetes, the sodium glucose co-transporter inhibitors. The mechanism by which sodium glucose co-transporter inhibitor lower heart failure hospitalization rates in type 2 are evident in many trials. The urinary sodium glucose excretion, increased fluid loss will lead to diminishing preload and afterload. There is a fluid loss which will improve blood pressure, shift of myocardium towards ketone, which is the favorable fuel for cardiac energy. And again, sodium glucose co-transporters cardiovascular outcome trials. In the EMPA-REG, using empagliflozin, you see elegantly that there has been improvement in hospitalization of heart failure and myocardial infarction, cardiovascular death. And in the Canvas, when they used canagliflozin, there was improvement in hospitalization of heart failure. And in the DECLARE, when they used the dapagliflozin, there was improvement in hospitalization of heart failure. It sounds that all members of this group share this property, improvement of hospitalization of heart failure and improvement in MACE problem. I would like to end by this slide. Professor Amara asked me to put this slide. This is the future modalities. What are the potential targets for future therapies? Number one, there is a medication in research which is called SN31, targeting mitochondrial oxidative stress. This is very important because it looks like it's tackling the pathophysiology when you have been talking about mitochondria. This drug in pipelines prevent diastolic function deterioration, prevents fibrosis, cardiac hypertrophy, promote oxidative phosphorylation. The second drug, which is going to be used futurely, is the coenzyme 10. It improves heart failure symptoms, reduce all-cause mortality and cardiovascular death. The gene therapy, the PIMA1 gene, improve left ventricular diastolic function, prevent cardiac apoptosis and fibrosis and development of heart failure. Lastly, we are going to hear a lot, and we heard a lot, about the microRNA, which is a potential biomarker for early detection of diabetic cardiomyopathy. Lastly, I would like to thank you for listening and attending with me. Thank you very much. Hayatan, it's a great pleasure to introduce one of the megastars of the Alexandria diabetes team, Professor Magdi Helmi Mgalla, which is going to talk about a very interesting topic. Professor Magdi is going to talk about insulin versus GLP-1 receptor agonist in treatment of type 2 diabetes. Please, Professor Magdi.
Thank you very much, Professor Yahya. You're my mentor. Thank you very much, my dear mentor and godfather, Professor Fahmi Amara, for giving me the opportunity to be here. Thank you, Professor Pulselli, for your excellent and elegant lecture. And I'm going to cover in the following 20 minutes the question of, is it insulin or GLP-1 receptor agonist in the treatment of type 2 diabetes? So, when it comes to injectable therapy in type 2 diabetes, the question is here, would you go for glutide or for insulin? Well, let's go to see just 2 or 3 real life cases. Here is Mr. Y. Mr. Y is a 56 years old teacher, diabetic since 7 years. He is obese and a heavy smoker. He is on metformin 2 grams a day, dapagliflozin 10 milligrams a day, and pioglitazone. He is having controlled the hypertension and dyslipidemia. He is now on high intensity statin. Well, his ECG stress test has shown positive results for ischemia, and the echo showing LVH, left ventricular hypertrophy, but the ejection fraction is fine. No evidence of reduced ejection fraction heart failure. The albumin to creatinine ratio is negative. He doesn't have chronic kidney disease, and the fundus examination is free. His glycemic profile is having increased A1C. His A1C is 8.2. So our patient here, Mr. Y, is having ischemic heart disease, but without heart failure, is having LVH, no chronic kidney disease. He is on a triple oral therapy of metformin, SGLT2 inhibitor, and glitazone. Well, the main cause is now in your office is that he is concerned about heart disease. And he should be concerned because 8 out of 10 type 2 diabetic patients do die because of cardiovascular disease. So, in view of this evidence of ischemic heart disease and left ventricular hypertrophy, what to do for glycemic control of Mr. Y? And the question again, are you going to add glutide or insulin? Let's go to the ADA, ASD consensus for this year. Well, it says that if your patient is having cardiovascular disease, you should add either GLP-1 receptor agonist or gliflozin, and he is already on gliflozin. And I'd like to point out here, this should be independent of A1C, even if your patient is well controlled. Insulin is in the bottom here of this part because simply insulin is neutral in terms of cardiovascular protection. It's not harmful, yet it's not protective as well. And we all know that glutides do have effects beyond the glycemic control that can protect the heart and the blood vessels. And the evidence is clear that results of cardiovascular outcome trials, and let me more precise to say, LEADER with liraglutide, SUSTAIN with semaglutide, REWIND with dulaglutide, and lastly HARMONY with albiglutide, all have shown positive results decreasing the MACE. Well, so looking at the patient's comorbidity, which is ischemic heart disease, this goes with glutide. But the question now, can glutide get this A1C of 8.2 to the target, say it's 7%? Well, glutides do act by multiple mechanisms. We all know that pathophysiology of the type 2 diabetes, one of the accepted models is the ominous octet. 8 mechanisms do play together for the pathophysiology of type 2 diabetes. Glutides do work on 5 out of these 8 mechanisms. And this interpretation is significant A1C lowering. Data from dulaglutide in the award trials have shown that you can get A1C around 1 to 1.5% lower with dulaglutides. In sustained trials, semaglutide have shown more positive results, and you have at least 1.5% reduction of A1C. So simply, you can get this A1C of Mr. Y of 8.2 to target by glutide. What else? The patient is obese, his BMI is 32. Well, and he wants to lose weight. Again, this in favor of glutides and not insulin. We all know that insulin is an anabolic hormone, and its use can lead to weight gain. Evidence from sustained trials with semaglutide have shown that consistent reduction of weight in all glutides do occur in variable degrees. And the ADA guidelines say that if you want to lose weight, you have either gliflozins or glutide. Mr. Y is already on gliflozins, so one of the smart ideas is to add glutide to his treatment. Look at insulin here. Again, the last choice if your comparative indication is to lose weight. Mr. Y is concerned about hypoglycemia. And who isn't concerned about hypoglycemia? Hypoglycemia is not only unpleasant symptom, but it can lead to serious cardiovascular events. It can lead to frequent admissions and high costs, accidents, social withdrawal, poor quality of life, and so on. So to reduce hypoglycemia, definitely the answer will be glutide, not insulin. And here is, if you're comparing indication to minimize the risk of hypoglycemia, you have 4 options. One of them is glutide. Insulin, again, the last choice in this regard. So in the ADA, the recommendation that if you want to intensify oral therapy and after failure of oral therapy, that please consider glutide in most of the patients prior to insulin. Again, because of cardiovascular protection, low risk of hypoglycemia, favorable effect on the weight. So for me, Mr. Y, if I'm seeing him in my office today, I would add GLP-1 receptor agonist glutide in favor of this patient profile. Leaving Mr. Y, and let's go to Mr. X. Mr. X is 48 years, accountant, type 2 since 12 years. His BMI is 21. He is now today, because of polyuria, polydipsia, and fatigue, he is depressed. He lost 26 kilograms over the last 3 months because of his blood glucose is very high. He is in the 30s range in fasting, 400 range in the postprandial. A1C is more than 11%. He is on metformin, vildagliptin, and the glyempiride. He is not having chronic kidney disease. He is not having cardiovascular disease. Well, what to do for Mr. X? He is really unhappy about this loss of weight and this polyuria. In the ADA guidelines, it's clear that when there is failure of combination of oral therapy that you need to add GLP-1 agonists. But take care. Here is a footnote that if the patient is having catabolic features, if the patient's blood glucose is exceeding 300 milligram per deciliter, if the A1C is exceeding 10%, please give priority to insulin rather than glutide. So for this patient, for Mr. X, with this very high glycemia and catabolic features and loss of weight, do you think that glutide can get this 11% A1C to target? The evidence we do have that the maximum you can get with glutides is having the A1C lowered for 1.5 or so. So I do not expect glutide to control this marked hyperglycemia. Again, this patient is unhappy with this catabolic state. So yeah, well, glutides do reduce weight, but for this patient in particular, for Mr. X, who will not like losing more weight. So for me, if I see Mr. X tomorrow in the office, I'll add for this patient insulin without hesitation rather than glutide, especially that your patient is not having evidence of cardiovascular disease, your patient is not having evidence of chronic kidney disease. And lastly, let me end by Mrs. Z. Mrs. Z's story is a bit different. She is 48 years lawyer, type 2 since 8 years. She is obese with BMI of 33. Well, recently, unfortunately, she had recent myocardial infarction. She went for PCI and 2 stents have been inserted. No heart failure, and the ejection fraction is fine. So she's having ischemic heart disease, and PCI was done with stent insertions, but no heart failure, fortunately. She is on metformin, sitagliptin, and the glycoside. Unfortunately, again, she had to discontinue gliflozins because of recurrent urinary tract infections. She is coming today because of, again, marked polyuria, polydipsia. Well, there is no evidence of chronic kidney disease. Her blood glucose is very high, and again, you have A1C approaching 12%. So our patient here is having established cardiovascular disease, but she could not tolerate gliflozin. She is not having chronic kidney disease. Her blood glucose is very high with catabolic symptoms. Well, what to do for this patient? Again, we've said that when you have a patient with catabolic features, please give priority to insulin rather than glutides. And her A1C is approaching 12%. So here, the name of the game is insulin. But she is having atherosclerotic cardiovascular disease as well. And she's eager to lose weight. She is concerned with weight gain associated with insulin. And she has the right to be concerned because she will get more weight gain with insulin. Well, for the cardiovascular disease here, if we looked at the ADA, her place is here. A patient with atherosclerotic cardiovascular disease like Mrs. Z, you need to give either gliflozin or glutide, irrespective of the A1C level. But she couldn't tolerate gliflozins due to recurrent urinary tract infection. So the secret, the password here is glutide. So she needs to add glutide to her treatment. Of course, you will stop sitagliptin because you cannot combine gliptin with glutide, and you can give glutide in addition to insulin in this patient. For this patient, for Mrs. Z, I would say that, well, stop sitagliptin and add both glutide for cardiovascular protection, for decreasing weight and insulin for controlling this marked hyperglycemia. Mr. Chairman, back to the question of, would you consider injectable therapy? Is it glutide or insulin? Well, it all depends on the patient profile. So if you have Mr. Y, who is having modest hypoglycemia, it's not the A1C of the 12 or 11 range. His blood glucose is less than 300. No catabolic features. He is overweight and willing to lose weight. He is having cardiovascular or chronic kidney disease or even multiple cardiovascular risk factors. Please go for glutides and be aware of the advantage that the hypoglycemic risk is little. If you have Mr. X having marked hyperglycemia, A1C exceeding 10%, no catabolic features, having no cardiovascular disease and marked weight loss, I would say that a patient with this profile, you need to give insulin and be aware of the disadvantage of higher risk of hypoglycemia. Finally, your patient can be a combination of both, having catabolic features, marked hyperglycemia on one side, and having cardiovascular disease on the other side. For these patients, for Mrs. Z and every Z, please combine both insulin and the glutide. So at the end of the day, to decide is it glutide or insulin, one size cannot fit all. You need to tailor therapy according to your patient's profile. And thank you very much for your kind attention.
Professor Magdi, thank you very much. It has been great as usual. You showed up a big landscape and you showed us a case which we can use a GLP-1 receptor alone, a case with insulin, and a case with a combination of insulin and GLP-1 receptor agonist. Lastly, but not the last, you said the notion of the name of the game that one size does not fit all. Lastly, Professor Magdi, thank you very much. Professor Puzili, thank you very much. And by the end of Professor Magdi's lecture, we end this session. Thank you very much again.
Thank you very much, Prof.
Thank you, Professor.
After we have listened to these three very important lectures in the first session, I have the pleasure to introduce my dear colleague, Professor Iman Youssef. She is the chairman of the diabetes unit at Alexandria University. She will talk about insights into the prevention or delay of type 2 diabetes. تفضلي يا أستاذة إيمان.
Good evening. Great thanks for my great professor, Dr. Fahmi Imara, to give me this great chance to speak in this honored meeting. My talk about prevention or delay of type 2 diabetes. Why diabetes is a global burden? This is because in 2019, the IDF estimates that 1 in 11 adults ranging from 20 to 78 years has diabetes, and 1 in 2 adults with diabetes are undiagnosed. Unfortunately, with 8.9 million diabetes, Egypt ranked in the 9th position among the world. Prediabetes is this term used for individuals whose glucose level do not meet the criteria for diabetes, but are too high to be considered normal. They are defined as the presence of IgG or IgT or A1C ranged from 5.7 to 6.4%. Among 88 million American adults, more than 1 in 3 have prediabetes. And more than 8 in 9 in 10 adults with prediabetes do not know that they have it. Prediabetes is commonly associated with visceral obesity, hypertension, atherogenic dyslipidemia, particularly hypertriglyceridemia and low HDL, and non-alcoholic fatty liver disease. It is considered as increased risk for type 2 diabetes and cardiovascular disease. As we all know that endothelial dysfunction is the earliest vascular abnormality related to both micro and macrovascular diabetic complication, and it is responsible for the initiation and progression of atherosclerotic process. The pathogenesis of cardiovascular disease in prediabetes is mainly due to insulin resistance, not due to hyperglycemia. So it is called insulin resistance-related cardiovascular disease. This is a classical concept of the development of type 2 diabetes that depends on interplay between insulin resistance and beta cell function. In the presence of insulin resistance and normal beta cell function, there is compensatory hyperinsulinemia and diabetes never develop. But in the presence of the abnormal beta cell function, there is relative insulin deficiency and type 2 diabetes. It was noticed that at the onset of type 2 diabetes, there is about 50% reduction of the beta cell function. As regards the natural history of type 2 diabetes, as we notice that at the time of diabetes, several years before there is insulin resistance, and the most important cause of this insulin resistance is visceral obesity. At the time of type 2 diabetes, there is a 50% reduction of the beta cell function, as we said, so there is increase in the hepatic glucose production, subsequent fasting, and postprandial hyperglycemia. As we notice here, that the development of macrovascular complication developed several years before the onset of type 2, and to less extent, development of the microvascular complications. Again, this picture shows that the macrovascular disease, particularly hypertriglyceridemia, low HDL, hypertension, and coronary artery disease developed several years before the onset of type 2 diabetes. Visceral obesity, it is known as a systemic chronic low-grade inflammation that leads to insulin resistance, type 2 diabetes, and cardiovascular disease. All these three abnormalities are arising from the same soil, which is the chronic low-grade inflammation. As we know that the visceral fat is a factory or a source of many markers of inflammation, atherosclerosis, hypertension, and thrombosis. So, insulin resistance leads to cardiovascular disease through endothelial dysfunction, hypertension, atherogenic dyslipidemia, thrombosis, type 2 diabetes, and visceral obesity. As we said, that also prediabetes is associated with microvascular complication, retinopathy, polyneuropathy, nephropathy by 8%, 13%, and 17% respectively. Diagnosis and screening of prediabetes. As we said before, it is either IFG or IGT or abnormal A1C. For the ETA recommendation, for diagnosis of prediabetes, fasting in 2 hours postprandial and A1C are equally appropriate for diagnosis. To avoid misdiagnosis, A1C testing should be performed using standardized method certified by the National Glycohemoglobin Standard Program. But using A1C may be problematic in certain hemoglobinopathies and conditions that affect RBC's turnovers, such as anemia, recent blood loss, and blood transfusion. So in such situation, only plasma glucose should be used for diagnosis. To confirm the diagnosis, either I can depend on two abnormal test results obtaining from the same sample, for example, fasting with A1C, or using two separate test samples. For example, I can repeat the initial test or I using different tests, but should be performed without delay. For example, I can do fasting glucose twice, or I can do fasting and after few days I can do 2 hours post-prandial. Screening and testing for prediabetes and type 2 diabetes in asymptomatic adults. It should be done every 3 years and should be considered in all people at the age of 45 years and adult at any age who are overweight or obese and have one or more of the additional risk factors that we all know. Patients with prediabetes should be tested yearly. Are you at increased risk for type 2 diabetes? The American Diabetes Association did a diabetes risk test, and we can download this application in our mobile. Depending on 7 questions, every question have a score or points, and if the total points or scores are 5 or higher, you are at increased risk for type 2 diabetes. Treatment of prediabetes. The aim of management is to prevent or delay type 2 diabetes and prevention of cardiovascular disease. 4 main items: lifestyle interventions, diet and exercise, metformin therapy, complete cessation of smoking, and prevention of cardiovascular disease. Several major randomized clinical trials demonstrate that lifestyle interventions in the form of diet control and exercise highly effective in preventing type 2 diabetes and improving global cardiometabolic risk. The most important is hypertension and atherogenic dyslipidemia. The strongest evidence from the DPP trial, Diabetes Prevention Program trial, that demonstrated that intensive lifestyle intervention could reduce the incidence of type 2 diabetes by 58% over 3 years. It is superior over metformin therapy that caused reduction only of 31% over these 3 years. As regards the medical nutritional therapy, we use carbohydrates that rich in fibers, including vegetables, fruits, legumes, whole grain, and dairy products. As regards the dietary fat, the Mediterranean style diet is the most important, rich in mono and polyunsaturated fatty acid, avoid saturated fat, and minimize the use of trans fat. Moderate intensity aerobic exercise best is brisk walking, a protocol of 30 minutes per day, 5 times per week, total of 150 minutes per week. Should be recommended in all patients. It improves the insulin resistance and glycemic control. As we said, total of 150 minutes per week, minimal frequency of 3 times per week, with at least 10 minutes per session. Also, resisting training exercise is recommended. Maximum of 75 minutes could be applied over a period of 150 minutes per week. It is important to reduce the disproportionate loss of skeletal muscle over adipose tissue. It increases the insulin sensitivity and the peripheral glucose uptake. So, the value of physical exercise is many. The most important is increasing insulin sensitivity, reduce the risk of cardiovascular disease, prevent or delay the onset of type 2 diabetes. As regards the pharmacological therapy, only metformin is important for the ADA guidelines. It should be considered in patients with prediabetes, especially in BMI more than 35, and especially below the age of 60, and women with prior GDM. Dose of 1.7 gram per day, it is highly effective, no risk of hypoglycemia, neutral for weight loss and weight change, potential benefits in atherosclerotic cardiovascular disease, neutral in congestive heart failure, low cost, neutral in progression of diabetic kidney disease, absolute contraindication if the estimated GFR is less than 30, it is called stage 4 CKD. It improves the ovulatory function in patients with polycystic ovary syndrome. GIT manifestations are common, but take care. Long-term use of metformin may be associated with vitamin B12 deficiency, so periodic measurement of vitamin B12 should be done and considered, especially patients having peripheral neuropathy or anemia. Patients with compensated chronic liver disease, metformin is safe, but the maximum allowed dose is 1.5 gram. The drug should be withdrawn in patients with decompensated chronic liver disease. Do other drugs have a role in the prediabetes? Various pharmacological agents used to treat diabetes have been evaluated for diabetes prevention. However, no pharmacological agent have been approved by the FDA and specified for diabetes prevention. For these drugs, cost, side effect, durable efficacy require consideration. Bioglitazone, ACT-NOW trial. ACT-NOW is a double-blind randomized prospective placebo-controlled study to study whether bioglitazone can prevent the conversion of high-risk IGT subject to type 2 diabetes. The results: bioglitazone reduced the risk of type 2 diabetes, conversion to normal glucose tolerance occurred 48% patients with bioglitazone versus 28% with placebo. Bioglitazone reduced fasting with 2 hours blood glucose and A1C. But take care, weight gain and edema observed in the bioglitazone arm. DPP-4 inhibitors. Some small studies showed that DPP-4 inhibitors improve insulin secretion and beta cell function in subjects with prediabetes. However, the evidence is not sufficient to support the use in prediabetes. GLP-1 receptor agonists. The scale obesity and prediabetes trial showed that liraglutide in a dose of 3 mg per day provided healthy in terms to reduce the risk of diabetes in individuals with obesity and prediabetes. SGLT2 inhibitors are showing important results to prevent or slow the onset of type 2 diabetes in patients with heart failure. The Yale University School of Medicine-led study was an analysis of the original DABA heart failure trial. Analysis reveals that dapagliflozin reduced new onset diabetes. 4.9% of dapagliflozin patients developed type 2 diabetes versus 7.1% in the placebo group. However, the evidence is not sufficient to confirm whether SGLT2 inhibitors influence the risk of developing type 2 diabetes or not. Vitamins and herbal supplementations. Routine supplementation with antioxidants such as vitamin E and C and carotene are not advised due to lack of evidence and efficacy and concern related to their safety. In addition, there is insufficient evidence to support the routine use of herbal supplements and micronutrients such as cinnamon, chromium, vitamin D, aloe vera, or chromium to improve glycemia. Thank you.
Thank you, Professor Iman, for this very informative lecture about the prevention of type 2 diabetes or the delay of its occurrence. And now we have the pleasure to present our colleague from Italy, Professor Frara Stefano. He will speak about diabetes and bone, the clinical influence of diabetes on osteoporosis. Please start, Dr. Stefano.
Oh, thank you so much for your kind presentation. And before start, let me thank all the organizing committee for this kind invitation. It is really a pleasure to be here virtually with all of you. And we have just listened about the risks of micro and macrovascular complications in diabetes. And now I will focus the attention on another significant complication of diabetes and the role of diabetes together with osteoporosis. When we are talking about diabetes, we know that every 7 seconds, one person dies from diabetes. And at the same time, osteoporosis causes fragility fractures every 3 seconds. So the burden of these two, I can say, pandemic non-communicable disorders is actually impressive. 1 in 3 women suffered of osteoporosis and fragility fractures, and actually 1 in 5 men, in particular those that are older than 65 years old, are affected by osteoporosis. So probably we are talking about the 2 more frequent disorders in the world. Starting from the history, since the link between diabetes and bone started when, at the beginning of the previous century, when a series of case reports about reduced bone mineral density and short stature in children with type 1 diabetes was published. This was in 1927. And then a series of studies and reports observed an increased risk for both vertebral and non-vertebral fractures in both type 1 and type 2 diabetes all around the world. And so I think we can start moving from type 1 diabetes, and a series of studies showed a low bone mineral density in patients with type 1 diabetes, both as compared to control patients and compared to type 2 diabetes. This is particularly true also in patients during prospective studies, where in follow-up, both younger than 20 and older than 20 years old patients showed a reduction in the increase of bone mineral density. When we are performing studies trying to evaluate the bone microarchitecture, we can observe, as compared to healthy controls, that patients with type 1 diabetes had a reduction in both trabecular and bone parameters. We can extrapolate this information from this study, for example, and you can see that both the microarchitectural properties of bones are in some way compromised. But when we are talking about osteoporosis, we need to evaluate the ardent point that is represented by vertebral and non-vertebral fragility fractures. And actually, we can say that it's something like an iceberg paradigm, since more than 50% of all the fragility and in particular vertebral fractures are still not detected. And this is why we need to pay more and more attention to look for fractures. In fact, patients with type 1 diabetes are at high risk for clinical and morphometric vertebral fractures, together with a correlation of bone mineral density and fragility fractures. We can say that patients with osteoporosis are really at very high risk to develop fractures, both mild, moderate, and severe fractures that may be associated with pain and impairment in quality of life. We know that a series of factors are associated with bone fragility, including, of course, insulin deficiency with the direct anabolic effect of insulin on bone, together with an impairment in IGF-1 production due to the liver failure. At the same time, hyperglycemia per se may cause an impairment of bone quality more than bone quantity, and together with a direct inhibition of osteoblast activity. At the same time, we have amylin deficiency that may contribute to decreased osteoblast formation. But we need also to think about many other factors that may influence and play a significant negative role in bone health. For example, we need to remember the high risk for other autoimmune disorders like celiac disease. At the same time, differently from type 2 diabetes, patients with type 1 diabetes have low BMI and may have high risk of hypercalciuria secondary to hyperglycemia and excess and the glycosuria that is physiologically caused by hyperglycemia. At the same time, we also need to pay attention in male patients that may suffer from hypogonadism. And all these factors altogether may significantly contribute to impair the bone quality. I think we can move to type 2 diabetes. And as we said, we briefly said before, bone mineral density is actually normal in most of patients with type 2 diabetes. This could lead us to a false conclusion, a wrong conclusion, say that patients with type 2 diabetes are not at high risk of osteoporosis. This is completely wrong, and we can say in the next slide that bone microarchitectures also in patients with type 2 diabetes is severely compromised, and in particular in those with both diabetes and prevalent fractures, so previous fractures. But at the same time, we can compare the ultradistal PQCT images showing that there is almost no difference between patients with fractures and no diabetes, and they have the same bone quality with patients with diabetes and no clinical fractures. So diabetes is something like already having fractures. So the impairment caused by diabetes is significant also on bone health. All the biomechanical parameters are reduced, and as you can see here, the cortical bone is compromised with an increased porosity, together with a reduced number of trabecular and increased space among trabecular. That is the black points, the black lines that we can observe among the white stripes that represent the trabecula in this PQCT study. Once again, we can observe also an impairment of bone quality in while performing histomorphometric studies that show a reduction in bone formation. And these, in some of these studies, they were associated with a reduction in serum osteocalcin, which is a marker of bone turnover and in particular of bone apposition. And together with a reduction of neoapposition bone marker, we can observe an increased levels of sclerostin, which is considered one of the most important experimental parameter to evaluate bone reabsorption. What can we do in our clinical daily routinely activities when we are performing outpatient visits and we have a lot of things to do together with bureaucracy, the patients, the glycemic controls, the exams, and so on? Well, in patients with type 2 diabetes, could be extremely useful perform trabecular bone score, TBS, which is performed on the lumbar DEXA scan. So this doesn't take much time because an algorithm may calculate the level of TBS, and so the trabecular bone score may clearly estimate the fracture risk of our patients and provide a useful and practical evaluation of what to do in patients with type 2 diabetes. Moving to the Haram point, we can observe in this meta-analysis that our diabetic patients are at high risk of hip fracture. And this was then confirmed in several other studies where we can, the authors try to retrospectively on your left evaluate the risk of hip fractures and correlate the risk of hip fracture together with glycemic control, or sex, or BMI, or prescription of insulin. And as you can see, we cannot observe any protective or negative factor that may influence the probability to develop fractures. And this is particularly true when we observe data coming from the Accord bone study, where we can observe that intensive glycemic control is not associated with a higher fracture risk. This is particularly interesting since we know that intensive control is able to significantly reduce the event, the cardiovascular events, but this is not really efficacious to prevent the derangement, the impairment of bone quality, and the risk of fragility fractures, both at hip, at vertebral level, and non-spine fractures. But when we are talking about type 2 diabetic patients, we need to pay attention also to many different determinants, including the increased risk for fall. We know that both neuropathy together with retinopathy significantly increase the risk of falls and therefore the risk of fractures, in particular the wrist and the hip or the humerus. We know that we need to prevent both micro and macrovascular complications, and this could be effective also in preventing fractures. At the same time, a series of patients may be at high risk of hypoglycemia, in particular those that are treated with insulin or sulfonylureas, and hypoglycemia per se could be considered a risk factor for falls. At the same time, we need to remember that most of the patients with type 2 diabetes suffer from low vitamin D level. And low vitamin D level is particularly frequent in patients with obesity. We need to remember that fat is not good for bone. In fact, adipose tissue may influence DEXA parameters, causing falsely normal BMD values. So in patients that are obese and with diabetes, sometimes DEXA parameters alone are not enough to estimate the fracture risk. We know also that the obesity is strongly associated with hypogonadism in males and precocious menopause or ovary failure in women, is associated sometimes in sarcopenia, and per se increase the risk for falls. The third thing, the third determinant I want to discuss with all of you is related to the effects of anti-diabetic agents on bone. And in particular, we will see the effects of oral therapies on skeletal outcomes. I start with metformin and sulfonylureas. This was a study that has been published, that was published a decade ago, comparing metformin and sulfonylurea with rosiglitazone. And comparing it with rosiglitazone, we will see the negative effect of thiazolidinediones on bone. We can observe both in terms of bone turnover markers that osteoclast activity, represented in this study by C-terminal telopeptide, is decreased as compared to patients treated with rosiglitazone. At the same time, patients treated with metformin and glyburide were observed to have an increased sort of reduction of also of osteoblast activity, but this was as compared to rosiglitazone, where we have an increased bone turnover and therefore both an increased, in particular, or resorption, but at the same time that is not actually compensatory enough with bone neoposition. So in patients treated with metformin and glyburide, both P1NP and bone alkaline phosphatase were slightly reduced. And in particular, this was significant for metformin, but was not reaching the significant level for sulfonylurea. But let's move to, once again, to the ardent point, and so in particular to fragility fractures, and in this case, in clinical fractures. Most of the studies were ineffective or inconclusive to show a significant influence of both metformin and sulfonylurea on fragility fracture risk. Of course, as compared to glitazones, they may have beneficial effects, but there is only one study that demonstrates a higher incidence of fractures, but was in a specific subset of patients that were in the male elderly with type 2 diabetes. So overall, we can say that the effects of both metformin and sulfonylurea on fragility, fracture risk is neutral. However, we can keep in mind that patients treated with sulfonylureas could be at high risk of hypoglycemia and therefore at a higher risk of falls. It's a pleasure to present a study that has been published a couple of weeks ago, and this is coming from a Taiwanese cohort population center. And as you can see here, they confirm that metformin could be in some way protective against osteoporosis and vertebral fractures, since the authors revealed a lower risk of osteoporosis and vertebral fractures in patients that used metformin disregarding for sex. And those that were treated for more than 2 years were shown to have a significant improvement in the skeletal outcomes. And so I think this is quite obvious, and all of you knows the negative effects of thiazolidinediones on bone. In particular, we know that glitazones simultaneously suppress the RANX2, which increase the differentiation of mesenchymal cells into osteoblasts. So when we are prescribing pioglitazone, or in the past, and this nowadays is pretty rare, rosiglitazone, we need to keep in mind that we are reducing the number of new osteoblasts in our patients. At the same time, we are activating the PPR gamma, which shifts the differentiation of the mesenchymal progenitor stem cells into adipocyte lineage. And so the final effect is a reduction of osteogenesis due to an impairment, in particular, of the osteoblast activity. When we are looking for bone mineral density, and so DEXA scans, DEXA exams, we can observe a significant reduction in bone mineral density, both at the lumbar and at the hip level. So we can consider both rosiglitazone and pioglitazone at high risk for osteoporosis. And our group showed this that a high prevalence of morphometric vertebral fractures was particularly true in male patients treated with both rosiglitazone and metformin. We published this study in 2009, and we observed that most than half, almost 2 up to 3 patients, male patients treated with rosiglitazone together with metformin experience at least one morphometric vertebral fracture. We proactively search for fractures, and we perform morphometry on X-ray lateral, both lumbar and dorsal spine images. In this meta-analysis, we can observe that the long-term use of thiazolidinediones doubles the risk of fractures, and this is particularly true in postmenopausal women that are per se at higher risk for osteoporosis. And we can observe an overall significant increased risk for fractures when we are putting together and we are analyzing together both males and females, but we cannot reach in this meta-analysis the significance also for men. So let's move to a newer drug class, and let's move to the incretins system. We can say that they have a protective or probably overall neutral effect on fracture risk. Just there is only one study that reported an increased risk for bone fractures in patients treated with taxagliptin, but this data was not later confirmed in a larger studies with population composed by older patients with type 2 diabetes. And then when we are moving to the more effective GLP-1 receptor agonist, we can see that there is a rationale to use this drug since that's been detected the presence of receptor for both GLP-1, GLP-2, and GIP on human osteoblastic cells. So we can hypothesize a role for the incretin system also on bone health. And these receptors were at least detected in different stages of differentiation. And once again, we can hypothesize that GLP-1 and GIP may play a role in bone differentiation and bone development. But when we are moving once again to the hard endpoint, which is the prevalence of clinical fractures, as you can see in this, of course, I'll show you a series of meta-analyses treating a so frequent problem. We can see that liraglutide was associated with a significant reduction in the risk of incident bone fractures, but the comparator in most of this study was exenatide, and of course exenatide, which is older than liraglutide, was associated with an increased risk of incident bone fractures. However, we cannot reach final conclusion since most of these studies were retrospective, and so there is a clinical need for future prospective and clinical randomized clinical trials to confirm the positive effects of liraglutide of at least of all the GLP-1 receptor agonists. And then we can move to the last drug class, which is these SGLT2 inhibitors. We know that the rationale at the basement of the consideration of SGLT2 inhibitors is this drug inhibits the glucose reuptake at the renal proximal tubule, increasing, of course, the glycosuria, and may potentially alter both the homeostasis of calcium and phosphate. Actually, data on bone mineral density, we can say, are inconclusive, since there is just one study reporting that canagliflozin has been associated with a decrease in total if BMD, but they did not reach the significance when we were evaluating the lumbar spine, the forearm, and the femoral neck. At the same time, we have to highlight that the other studies on the other SGLT2, and in particular dapagliflozin and empagliflozin, show a neutral effect of both marker of bone formation and reabsorption, and have no overall effects on bone mineral density. So there is current no evidence suggesting a significant increased risk of fractures in patients with type 2 diabetes treated with SGLT2 inhibitors. We can say that it's not true for canagliflozin, that has been associated in one study to an increased risk, fracture risk. In particular, in this study, fractures were detected, were reported in the upper and lower extremities, so not typically of osteoporosis, excluding the wrist fractures. And those patients that experienced fractures were those with a high cardiovascular risk and a longer history of diabetes and complications for diabetes. And so probably all the final effect was mediated by a higher risk of falls. So we can say that also SGLT2 inhibitors have a neutral effect on fracture rates. So what can we do when we are approaching our patient with diabetes and we are prescribing, for example, new drugs? First of all, we need to check for lifestyle intervention with medical nutrition therapy and exercise, and possibly taking in mind that most of our diabetic patients are affected by hypovitaminosis D. And so we need to correct hypovitaminosis D to prevent osteoporosis. When we are prescribing drugs, thinking about the risk for osteoporosis, we should prefer, in particular, metformin, incretins, and avoid, of course, hypoglycemia. We are pretty sure that thiazolidinediones may play a negative effect on bone. Our judgment should be suspended for both sulfonylureas since the effect is neutral, but they are at high risk for hypoglycemia and so the higher risk for falls. And new studies are needed to better clarify the role of SGLT2 inhibitors. But it's actually really important to prevent osteoporosis, and thinking about our patient skeletal health, we are thinking about the heart, the kidney, the brain, the vessels. We are taking care of our patient altogether and not just looking for glycated hemoglobin or glycemia. And it's particularly important to take care of the bone health, since osteoporosis has been, in patients with diabetes, has been clearly correlated with a reduction in quality of life. Patients with osteoporosis, in this study that has been published a couple of years ago, were shown to have an impairment, a significant impairment in quality of life, in particular in those subset evaluating the physical functioning, the physical activity, the social functioning, and the emotional role of both diabetes and osteoporosis, and the impact, the social emotional impact that these two non-communicable disorders has on the life of our patients. This was particularly true in patients with vertebral fractures, where patients that already experienced vertebral fractures show a reduction in quality of life, with an increase also in pain and in quality of the general health and the perception of general health. But diabetes and together with osteoporosis does not only affect quality of life, but also mortality. We need to remember that patients that experience hip or spine fractures have a significantly increased risk of mortality. We can say, for example, that in Italy, 1 in 5 patients that experience a hip fracture will die in the next year due to causes related to osteoporosis and diabetes. This is a significant, this has a significant impact on the social system, because we have an increased mortality and an increased expenses for the national health systems. And also we can remember the social impact on the families, on the caregivers, and so on. So in conclusion, we have observed that diabetes is burdened by a high risk of osteoporosis and fragility fractures through different pathogenic pathways. In patients with type 1 diabetes, bone mass is particularly affected, whereas patients with type 2 diabetes usually show an impairment in bone quality. But all these patients are at high risk for fragility fractures. Even though micro and macrovascular complications are associated with high risk for falls and fractures, we cannot say that intensive glycemic control may improve the skeletal health. We have observed clearly that glitazones have been related to osteoporosis and fragility fractures, whereas incretins may probably play a positive effect on skeletal outcomes. When we are treating our patients and not their blood exams or their urine exams or radiological exams, we need to keep in mind that life expectancy and quality of life in patients with diabetes and osteoporosis is significantly compromised and reduced. And I'm going to thank all of you for the attention, and all my colleagues, my mentor, Professor Justina, for the support and the activities that we perform on research and clinical every day. Thank you, everyone.
Thank you very much, Dr. Stefano, for this very illustrative lecture that added spotlight on, especially on the drugs to use and drug to avoid, especially on those prone to osteoporosis and so on. At the end of this session, I have to thank all the speakers, our 5 speakers, Dr. Puzzilli, Dr. Ghanem, Dr. Magdi, Dr. Iman Youssef, and Dr. Stefano for their very illustrative lectures today. And before ending our session, our wave 1 today, I have also to ask ICOM team for helping professionally with all the logistics during the meeting. And I hope that we'll meet tomorrow at 3 p.m. Tomorrow at 3 p.m. for the wave 2 of our event. And thank you very much for all of you. Have a good night. Thank you.
Have a good night. Thank you.